Good day, everyone. My name is Jessica Porras, and I'm the Senior Manager for Education and Outreach at CAQH Core. It is my pleasure to welcome you today to our CAQH Index Report webinar. I'd like to mention a few logistical items. You can download a copy of today's presentation from the caqh.org website after the end of the session. To do so, navigate to the Core pull-down menu at the top of the caqh.org welcome screen and select the Core Education Events page. A link to the PDF version of the presentation can be found under the listing for today's webinar. I'd like to emphasize that the slides aren't there now, but they will be available for you to download after the webinar. On this slide, you can see a screenshot of the attendee GoToWebinar dashboard. When joining today's session, it's possible you may have joined the audio portion of the webinar using your computer speakers by default. If possible, we prefer you to join the webinar audio by telephone. To do this, please select the telephone audio button in the audio panel of your dashboard, and the dial-in information will be displayed. Make sure you enter your audio PIN, which is found under your dial-in information. We will save time at the end of today's program to respond to your questions. You're encouraged to submit your questions at any time during the webinar by typing them into the questions panel of your dashboard. I would like to thank our guest panelists from Aetna, Tom Conklin, who is the Director of Provider Website and Reporting Analytics for Provider eSolutions. Thank you, Tom, for joining us today. So let's go through the agenda. Today, we will start off with a presentation on the CAQH Index, followed by a presentation about Core's work to move the industry to electronic healthcare transactions. And then we will engage with our speakers as well as our guest panelist from Aetna, who's a participant in the CAQH Index, to talk in a little bit more detail about the value of the index, what it means to participate in the index, and some other topics of interest. So let's get started. I'd like to introduce our first speaker, Reese Kaiser, who's the Interim Director for CAQH Exploration. Reese?
Thank you, Jessica, and welcome everyone to today's webinar. Just to set the stage and give a little bit of background on what is the CAQH Index. It's a nationwide survey that covers commercial, medical, and dental plans as well as healthcare providers, and it's done on an annual basis, and it's voluntary, and we publish those reports to drive visibility into the adoption as well as the cost savings around the movement or transition from electronic transactions from manual. And it's the only industry set of benchmarks that are out there measuring that volume as well as looking at the different costs associated with those transactions. And it's really beneficial and critical to monitoring that process as we move through simplification of business transactions between payers and providers, and really goes back to you can't improve what you don't measure. So it sets that industry standard of metrics that are measuring the adoption of these various transactions. The index has been with CAQH since 2012, and it is managed by CAQH, but also guided by a council of experts that really cover a variety of different stakeholders and experts in administrative transactions, data analysis, healthcare management, as well as from the consumer advocacy side as well, and really look at across the various stakeholders from patients to industry providers or partners, health plans, and vendors. And also, we are supported here at CAQH with our studies, with our other partners, with NORC of the University of Chicago, as well as Milliman, and doing the various studies with providers as well as clearinghouses and vendors. So as we know, for over 2 decades, HIPAA has established the requirements for the adoption and use of electronic transaction standards in conducting and transacting business. Yet we still see and rely on a lot of manual resource-intensive processes. And the index helps to measure that industry transition in looking at electronic real-time transactions and helping to push and move towards a modern healthcare system where, according to the Kaiser Family Foundation, the opportunity to save more than $31 billion annually could be achieved in conducting basic business transactions between payers, and health plans. The other key pieces that really drive why the index matters to the industry, not only in looking at the reduction of unnecessary healthcare costs, but think of the adoption or moving to a fully electronic or more electronic system in easing the provider administrative burden or some of the hassle factors that go into transacting business between payers and provider, as well as the time savings that are associated with the back office staff in managing those transactions. And that also is part of really complementing the revolution in the use in health information technology. We all strive to move towards a more efficient, integrated healthcare ecosystem. And as we continue to transition from a fee-for-service to value-based payment models, the importance of tying the transactions of claims and claims information and attachments to clinical data will become more and more important, and having better connections will help both the payers and providers as well as consumers of healthcare in moving this system forward. Here I'd like to just highlight a little bit of what the index represents. Currently, we have been reporting the index based on health plan and healthcare provider data that you see collected. We've been collecting and reporting medical data, as I stated earlier, since 2012 and 2013 was the first report by CAQH. This past year, the 2016 report that we're walking through the results today, this is the first time or the first year that we've reported out on dental health plan data as well. So the index continues to grow. As you can see from the medical health plan side, we are at 140 million covered lives there, and as well as on the dental side from 112. Now, just to be clear, this was 2016 was the first year we reported dental data, but we have been collecting it for 2 years there, but now had a robust data set, and we're able to report some of those results that I'll show here in a few minutes. Just quickly, this slide gives you a snapshot of the set of transactions that are currently analyzed, recognizing that there's many more transactions that are out there, and really the index report is only really showing the results and cost savings directly from this set of transactions. So the opportunity of those cost savings is obviously much greater than what you see currently reported in the CAQH index as of 2016. And we'll continue to grow and evolve and add additional transactions as well as stakeholders. For example, we are doing a additional study and data collection around the clearinghouse and practice management vendor cost, also as well as adding different transactions like acknowledgments, and then also expanding additional transactions in the dental space as well. Now, while I won't go through all of the details on the results that we saw in 2016, I highly recommend going to the CAQH Index website and downloading the 2016 report. It has a wealth of detailed information that's in there, transaction by transaction. It also goes into more on the methodology, the limitations, and other key characteristics behind the report. And my contact information is provided at the end of this presentation, and I'm always happy to take individual phone calls to walk through any questions on that report. But from a high level here, you see the aggregate results, and we have seen that there has been a modest but very positive trend over time in the increase of electronic transactions. You'll see here we have medical on the left and dental on the right. It's here. Now keep in mind that the dental side is a little bit earlier, or I guess a little bit later within the measurement process and as far as participation here. So while you may see a 30-point difference in comparing the two, I think the key message really here is to see that we're at the early stages of this. There's a high interest level with the different constituents and stakeholders within the dental world. And we see the positive trend increasing, and with time we expect for those results to increase upward as well, and somewhere in line with what we're seeing on the medical side. But recognizing the medical side has been looking and doing these transactions for much longer period than may have been the focus in the dental community. there as well. So keep in mind as well, we see that claim submissions are on the higher end, approaching that 100%, and we would not expect things to ever reach 100%, but the key is that we are seeing a lot of great progress in pushing claim submission up there in the high 90% area. And as I stated, the other ones are showing progress, but still have some lag and continued progress that are going there. But those will hopefully continue to increase as we focus and bring visibility on those different transactions. But keep in mind that things like eligibility, benefit verification, and claim status inquiries, where we are seeing progress in the adoption of electronic transactions, we are also not seeing necessarily the equivalent decrease in manual. So while those channels or opportunities to conduct those transactions electronically are increasing and are happening, they're still resulting in some of the manual transactions and follow-up, and whether that's the provider submitting an inquiry but then following up with a phone call to do a current check that goes there as well. So keep that in mind, that even with some of these increases, and there's a great breakout within the report that will show a further example on the increase in the electronic, but also the relatively slower decrease on the manual side of the transactions that are occurring in addition to that as well. One other key new highlights in the 2016 report was the beginning of looking at claim attachments and tying some of those healthcare or clinical related components to claims and transacting those electronically. From our sample that we had, we showed only 6% of these claim attachment transactions are being submitted electronically. And of those, it was only through X12 and not through HL7. And we know that HL7 is more the industry recommended set of standards with that. So it's one early data point. I'll caveat it with that. It's an early data point, and we are continuing to increase the participants that are submitting or contributing this data. So we expect to hopefully glean some different and more robust results that will show some increases in overall with the amount that are electronic, but also see if we can learn more around HL7 transactions there as well. And keep in mind, this is a very expensive transaction. The cost savings around claim attachments can be more than $6 per each of those transactions. So shifting to the next slide, and actually the next couple of slides, these really give you a view of what we saw in the data that we collected from the payers or the health plans. From the medical side, we see roughly about 36 transactions on average, or in aggregate, I should say, that occur for each member, with 11 of those being claims and the most frequent being eligibility and benefit verification, and that's roughly about 17 transactions per member. And on the dental side, you can see it's a little bit different, but probably in line with what you would expect in the transaction or in what happens in the dental space of healthcare. But roughly, you'll see about 6 transactions per member here, with 2 of those being claim submission, 2 being eligibility benefit verification, and you can see a fraction being a claim status and claim payment. And keep in mind, these numbers are rounded to the whole numbers that you see here. As I mentioned earlier, we have only began reporting on the 4 transactions for dental that you see here, but for 2017, we are beginning to also collect remittance advice, attachments, and acknowledgments as well as 2017, and we'll continue to grow and do all that as we work with our dental contributors through time as well. Now, new this past year, and something that we did in working with NORC through the provider study, is we began reporting the actual time spent by provider in doing these transactions, and this has really been a great data point that has received a lot of interest and different inquiries to CAQH, as well as at different conference presentations here as well. And I think it really gives us something tangible to really look at and relate to, and whether that's us on the healthcare delivery side, or even thinking it as a patient and going through it and what that means to the added cost of healthcare. And personally, I find it, very amazing that if you were to look at a single claim that required each of these 6 transactions, the time savings associated with that could save a minimum of 51 minutes. So think about that. And typically, when I go to my primary care provider, I can tell you I don't spend 51 minutes with my primary care provider. So think of their office staff in the background doing all this additional work that may not have really any value to the care that's being delivered. The other key takeaways to think about on this slide or to look at is really in looking at each of these transactions and the ranges of time. There's obviously a wide variability within each of these transactions and across transactions, and that infers or indicates that there is a lot of opportunity for standardized processes and workflow patterns as well for office staff through electronic transaction systems. Once again, there's a lot of information on this slide, and I once again will recommend downloading the full report. This is a great resource for folks if you're really wanting to look at the detail of the cost for those transactions, whether that's communicating up to your leadership or your constituents on the benefits of electronic transactions. But really the key takeaway here is there's about a $4 per transaction saving for provider and $3 for health plans, so that comes out to roughly about $7. And as stated, we haven't even included the vendor costs that could be associated as intermediaries within that, so that number could be even higher. And one might say, well, it's $7, and that's roughly maybe the price of a cheap pizza. But if you think about adding up all the transactions that are occurring, that's a pretty large stack of pizzas at the end of the day that could be had. Here's a breakout of our rollout of our overall industry cost savings. You can see that if you're to add what we've measured through the medical health plans and dental health plans side of the savings opportunities between payers and the providers, it comes to roughly about $11.4 billion of that $31 billion target that's out there, and just looking at these 7 transactions. So in winding up my presentation, really the key things in the call to action is that we at CAQH obviously recognize that there's been significant progress that has been made, but recognize that the transformation is far from complete. We continue to drive the index to really build the awareness as well as industry data, actually the only set of industry or national benchmarks that support the efforts to evolve from manual to electronic processes. And really the other components that we see in driving the industry forward is through the index and through our contributors and participants, is to really share and expand on the best practices around increasing the adoption and transactions. And I know Bob will talk a little bit more about the core rules as well coming up shortly, and the different industry-led efforts that are out there to reduce those barriers between payers and providers in conducting these transactions there as well. And then obviously we all are looking to continue to move our healthcare system to a more efficient one through different technical and policy requirements, as well as innovations that are coming throughout the ecosystem that are there. So for those that are interested in participating in the index, please contact me. Here you can see the different pieces behind participation. Like I said, we are working with health plans and providers in collecting and reporting the data. We've also begun with Milliman and looking at the vendor side. So really, whether you're a health plan, a provider, or a intermediary or clearinghouse or practice management system vendor, we're interested in having you become a contributor by contacting me. In return, as far as doing the good thing and contributing that data, you get in return a benchmark report that will show you basically how your organization is comparing to the others that are contributing data to the index. And I will be very clear and state that all of your individual data that is contributed to CAQH is kept in confidence and not shared externally with any others other than you through that benchmark report. And just in final closing, this is really just a snapshot. We do provide a very detailed user's guide or submission guide that basically defines the different transactions and the different components to that so that we have a standardized set of metrics that all contributors are finding. And on the right side here, you can see just a screenshot of what that data collection tool looks like for claim submissions there. So with that, it concludes my overview of the CAQH Index, and I'd like to hand it back to Jessica for a first polling question.
Thank you, Reed. That was a great presentation, and given all of the resources that we see here and some of the information about the value of participation, hopefully we can go to our next polling question, which is, are you a health plan or provider interested in participating in the 2017 CAQH Index? So this is a question for health plans or providers, but as we just heard from Reed, vendors can also participate. So I think even though it says not a health plan or provider, I think what we want to do is have the answers be yes, no, already participating in the index, or unsure, need more information. So let's start the poll and see what kind of information we get. And Reed, it sounds like, the more participants, the better, right?
Absolutely. So, and that's the one thing that I've seen from the evolution from when I was a part of transitioning the index over to CAQH in 2012 is just the growth in the number of participants that are coming into it, whether that's from the health plan side or the provider side, but even bringing on partners like Nork and Milliman as well. So with any type of analysis, the more robust the data, the more informative, the more valid, the more actionable for the industry it is. So we highly encourage folks to participate. And I know Tom will talk about some of the benefits from his perspective at the health plan and what it means to them in participating and what some of those level of efforts take to do it. Is it a big or small time commitment to participating?
That's right, and we're looking forward to that presentation so the audience can get a little bit more information. So let's share the results. And Reed, I think you and your team are going to be kind of busy. So as you can see, about 9% are already participating in the index, and thank you so much for that. And for 15% said yes, and 35% said unsure. So we've got a lot of follow-up to do to talk to some of these folks and see if they're interested or what kind of information we can share to get them to the yes, right? So let's close the poll. And now our next speaker is CAQH Core Associate Director Bob Boatman, and he will walk us through the role of Core in moving the industry to electronic healthcare transactions. Bob?
Great, thanks, Jessica. Thanks, Reed. And as both of you mentioned, we do want to talk and give you a quick overview of what CAQH Core, what our mission and vision are. And really, our drive to create and both adopt the healthcare operating rules and their underlying standards to ensure that we're accelerating interoperability and looking and aligning how the administrative transactions and the clinical activities that take place at a provider and a health plan and throughout the industry, how we can align those types of transactions, the data sets, the connectivity, how we ensure that the different constituencies and those stakeholders can work together better. So we are an industry-wide facilitator of a trusted and simple, sustainable health care data exchange that evolves and aligns with market needs. And that market needs is really important because, as Reed mentioned, not only does the index have its participants, CAQH Core has its group of participants as well. As a robust group of 130 plus entities that really work through our integrated model in developing and researching potential rules, designing those rules and offering certification, building awareness and education, promote adoption of the transactions and the operating rules. We report through ROI and our progress of the adoption of the rules. And part of that you'll see is kind of reflected in the index report. But we also do our own tracking for certain key measures too, for the number of certifications, market share analysis. We look to see how many lives are covered by entities that have become core certified. I want to share some of that information with you today. So on the next slide, how much, what really are the roles of the operating rules? And the role of the operating rules include, really we're trying to facilitate that interoperability for the administrative transactions to make sure that as more people adopt, that it's easier and easier to use, the data is available for the provider as well as the plan, and the intermediaries lying between the vendors and the clearinghouses are part of that solution, right? So we want to make sure that we complement the work that each one of those organizations is doing in each part of that equation. So we support both industry-specific, healthcare industry-specific standards like the X12 standards, as well as industry-neutral standards. And we look to see throughout different industries what are the best standards that we can use as a healthcare industry to help facilitate the business interactions between providers and plans. And so we look at that environment and set up our rules in two different ways. We develop infrastructure rules. Again, these apply across the transactions. It includes things like connectivity and security, response time, system availability, roles and responsibilities of trading partners, acknowledgements, and companion guides. And we also look at within the standards themselves, we crack them open and look at the data content. What data is that's within that standard that may or not be turned on? The switch isn't turned on, right? It's maybe it's optional data. If we turn that optional switch on and we make it required, there might be a better benefit in using that standard by allowing, for example, co-payments. We ensure every time a provider sends in an eligibility transaction that the health plan responds with the co-payment, the co-insurance, and remaining deductible. So immediately the provider knows exactly what they need to collect from the patient at the time of service, or how to have that conversation with the patient at the time of service about the funds that are required for the service. So we look at these two buckets, the infrastructure requirements and the data content requirements, as we develop our operating rules. Moving on to the next slide, how much could the industry save by adopting the operating rules? And keying off of much of the data from the index, but really just focusing on 6 of the transactions. And these are just the top 6: eligibility, claim status, claim payment, the remittance advice, claim submission, the claim itself, and the referral, the prior authorization. Just by looking at those 6 transactions, probably the most common 6 administrative transactions, included within the index is 5.4 billion transactions. We only looked at these 6 transactions in the commercial space. How much money could the industry potentially save by migrating from a manual or a paper-based telephonic process to a complete EDI transaction for these 6 transactions? And it's over $9 billion. Again, that's really just a small portion of the potential savings, as Reed mentioned, because there's so many more transactions that could take place electronically without manual intervention, without a manual process, without the telephone or the fax. So just looking at, again, claims and eligibility, migrating providers over to using those electronic EDI-based transactions, the industry has a great potential to save billions of dollars. So again, not only are the savings important, but some of the administrative simplification components are also important, and why to adopt the operating rules. And some of that you'll find on the next slide. So why should we implement the operating rules? For example, providers, just looking at the use case for providers can save 7 minutes and almost $3.60 for every healthcare eligibility verification that they switch or convert from a telephone to an EDI transaction. Providers saw when they do that, when they verify eligibility for every patient that comes in the door, they reduce their claim denials by over 10%. By migrating from a paper remittance advice and a paper check to an electronic remittance advice, the 835, providers can save 12 minutes in processing that remittance advice and $4.74 per transaction. Again, looking at providers who switch from a telephonic or a fax process for prior authorizations to an electronic EDI, PA, they can save 14 minutes and $5.61. So the savings is built in for every transaction that the provider conducts with a health plan. Looking at other use cases and other reasons why to adopt the operating rules, on the next slide, we've taken the approach to show some examples from each of the phases. So again, it might be too hard to adopt and implement all 4 phases at once, but even taking a phased approach for the operating rules, implementing phase 1 and 2, for example, first, and then phase 3, then phase 4, we've seen a lot of success by both plans, providers, vendors, and clearinghouses taking that approach, biting off what they can chew today, and then looking at what they can do tomorrow. But those savings and benefits are still present every step of the way as you implement the operating rules and the standards. Faster patient registration, improve the revenue life cycle if you're validating the eligibility for each member that walks in the door. You can, in phase 3, improve your cash flow because you ensure that you're expediting the payment. The payment from that plan is coming in sooner on the CCD Plus or the EFT transaction. You can also reconcile your AR much quicker because you're receiving an electronic transaction for the remittance advice data. Phase 4, you can also continue to enhance that revenue cycle because you're going to be receiving and you're submitting your claims electronically, but now you'll be able to receive acknowledgments, so they're not falling into black holes. You know exactly when they're acknowledged. The 270CA, the claims acknowledgement, there's a specific transaction that's required in phase 4 that lets the provider know that the claim has moved from the front-end edits of a health plan to the back end for formal adjudication. So the provider has more knowledge and more information about the claims that they submit earlier in the claims process, so they can make adjustments as needed instead of waiting all the way till the final adjudication and the 835 comes in showing that it's denied, right? If you had that information sooner, you can make adjustments and rebill and resubmit that claim sooner to fix those types of errors. So again, there's lots of benefits, and they touch each component of the administrative transactions that the provider submits to and or receives from the health plan. If we move on to the next slide, I believe that we are ready for our next section here. So I'll hand it over to Jessica.
Thank you, Bob. Thank you so much for that presentation and that very helpful information. And so I'd like to take a few minutes to talk to our 2 speakers. And also, we are also joined by our guest panelist, Tom Conklin from Aetna, and I'll moderate this portion of our webinar. Thank you so much, Tom, for joining us today. And I want to ask you the first question. What were the main reasons that Aetna decided to participate in the CAQH Index?
Yeah, there are several. First of all, thanks very much for having me. Those are very informative segments from Reed and Bob, and I think Reed touched on a lot of the value that we see and continue to see in participation. The fact that it's the only game in town, it's the industry standard for this type of data, and we find that extremely valuable, as well as a tool for us to monitor our progress towards eventual full adoption of electronic transactions.
Thank you, Tom. So a follow-up question for Reed on that. When you talk to people who are participating in the index, are those reasons consistent with Tom just said, or have you heard other things?
Yeah, they're very, very consistent with what Tom said. And just to add, let me just echo, I guess, on the first point is that most of our contributors, they're very excited to get their benchmark report back at the end of the year into the analysis cycle. They will take that to their leadership and use that for their various internal presentations, whether that's to show how they're progressing or build a business case for more investments to do different things from a systems development perspective, but then also even from the health plan side of thinking, are there provider incentive opportunities as well to get providers to adopt these different electronic processes. And then to add, I would also say that it's not necessarily from a participant perspective, but there's definitely been a lot more interest, I would say, in the last 2 to 3 years from external entities, and whether that's media, others that investors even looking at what's going on around these different administrative processes. And I think that our contributors recognize the importance of contributing to that and really building out, doing the right thing for the industry to have this robust data set that really gives you hard data to standardized data that's comparable in how one organization is defining the transaction to the next, and having data points to really go back and say, hey, we have this information from the index that supports our case or brings visibility to those different issues. So it's really a lot of, I think, a public awareness is a lot of the feedback that we get. Is that's the great thing that the index is bringing to the industry, as well as pushing.
Yeah, and based on what you just presented, we're talking about large savings and large efficiencies. So I can understand why there's a lot of attention to
Right. Yeah, and just, I mean, once again, from a personal perspective and from a bigger picture perspective, and as we talked about from the shift in value-based payment models, we haven't even begun to really go into look at things around clinical data exchange and what's going on there, and we know that'll become more and more important. So here's a set of measures and metrics that is set a standard for measuring the adoption of a set of different business transactions that are happening out there between payers and providers.
And as you're out there talking to the various participants, do you notice any difference between the stakeholder groups or the plans or the providers? Do they have different or unique reasons for participating in the index?
Yeah, I think, yes, they do. From the health plan side, obviously there's, they're going to be working more of an economies of scale. They're working on, larger sets of transactions that are coming in. So it really, to Tom's point, is looking at how things are progressing, where there's those opportunities to improve. On the provider side, there's definitely, especially when you put these statistics out, that there's 1.1 million hours a week that could be saved, or 51 minutes per claim that's submitted, in recognizing in today's busy practice environment where there's a lot of cost pressures and efficiency pressures that are there, is participating in this gives those practices the opportunity to sit down with their staff and for experts like CAQH and North to sit down and walk through and help them, one, evaluate or baseline or benchmark where they're currently at, but then also get a better understanding of, hey, what are the things that we can do that are either best practices or that we can improve, or different transactions or channels that we can use to conduct business electronically. So providers see it from a little different perspective and being a little bit farther behind on things just because of where they're at currently in the time scale of adoption of electronic.
And probably the same thing for the dental.
Exactly. So yeah, so the same type of thing for the dental. And actually, it was great to have dental reported out this year. There continues to be a lot of interest, obviously, from the medical plan side of things, but for the dental plan side, it's just amazing the energy and interest that there is there. So I continue to see that grow, and we actually have pretty significant increase in interest in dental plan contributors this year that we're excited about.
That's great. That's good to hear, and it's something that we'll keep working on, right?
Right.
So now I'd like to ask Tom a couple questions, from your perspective as an index participant. Can you tell us about your experience engaging and getting the go-ahead from your leadership, and how involved was your leadership in the process?
Sure. Thank you. Yeah, it really was a very easy sell. I think the power of the data that Reed just alluded to really speaks for itself, and that leadership immediately sees the value of participating in this type of exercise, as well as it being, the right thing for the industry. I think Aetna has been a strong supporter of CAQH and what they're trying to do for the business of healthcare. And this is just another one example or one focus that carries a lot of weight. So we are a national payer. But it's interesting to see just the volume, the power of how many transactions and lives covered are represented in that survey. So I think that's very compelling for leadership, and a lot of the points that Bob and Reed have made, could certainly be included in a conversation to get buy-in to do it. And I think we're going to get on to some. So I'll hold back on some other comments for some other questions. But I mean, basically, there's a lot of value for very little upfront effort,
So
and I
that's
think
great,
that's plain to be seen.
No, that's great. And, and for those of you out there who maybe need a little bit of help making the case and, engaging their leadership, I'm sure that we can help. So Tom, you've done this for a while, so can you walk us through what it means to participate in the index in terms of resources, time, staff, et cetera?
Sure. I think it's gotten a little bit better every year, but the reality is that the team at CAQH provides a very slick template, instructions, as Reed said, making their resources available to help people get familiar with the tool and completing the survey. And again, it's fairly straightforward. So once you kind of get a sense of all those different categories, then it's just a matter of gathering the data. So I've got one analytics person that basically is gathering transaction volumes, and then we work with our business partners to come up with some of the cost information to get that full all-up cost, which is an essential piece of the survey as well. That can be a little bit more challenging, so I think you need to leave some time, but once you do it once sort of thing, it just needs a little tweak every year to confirm that the values are still accurate, and then just go from there. So it really kind of completes itself once you've done it one time.
Okay, so that makes sense, that you kind of learn and improve a little bit as you go along. Were there any other challenges that you encountered as you were doing this work, any kind of lessons learned for our audience members?
No, I think just leaving adequate time to get the buy-in and to get those consistent definitions, if you will, of costs. So different P&Ls may track that differently, so you need to normalize that data. But once you've done that, then like I said, it kind of carries over from year to year, and you're just making small edits based on any changes in the numbers.
Yeah, this is Reed, and just to add to Tom, something you hit on that's key that we've seen from our eyes or perspectives in working with some of these plans. Obviously, coming in for the first time, if you already are looking or doing calculations around these transactions, there may be some differences in how those contributor, or I should say, health plans or participants are defining those different transactions that we're calculating. So they actually will learn or start to follow more of the standardized definitions that we're using that are communicated or lined out within that data submission guide. And then also they'll begin to start thinking about what are other analytics that we want to look through. So it really is an evolution, I think, for many of the participants. And when they first come into it with one view of the world and now seeing all these different things and then getting more of that visibility and starting to think about other things, it's fun and interesting to watch how things progress over time and their interest and transition as well through the process. So what it may look like or what the lift may be in year 0 or year 1 is obviously different, but progressing in a very positive direction by year 2, 3, 4, and beyond. So that's been another, I think, a great piece that's come through that we've seen through participation.
And what you're saying is a great segue to my next question for Tom, because I want to know, how useful is having this data as you make business decisions or decide what areas might need more or less attention? How valuable is this index data?
I think it was Reed or Bob mentioned that the benchmark report that comes back every year, and that's the payoff. So you do the work up front, and then CAQH crunches the numbers and puts it into a very slick and easy to follow presentation, if you will, or report that is really very powerful. So you see where you stand, your results against the field, if you will, or all the other participants in the index across a wide range of metrics and measures. So I think it is very powerful, and then it can be used internally to identify goals or areas for improvement, opportunities, seeing where we are against the field, or where do we have opportunity to focus and perhaps improve. And I think it paints a very strong story for the value of electronic transactions. So you say, well, look, I don't think people have a good sense of how much the manual process really truly costs, and this index report provides that in a way that we really isn't done in any other form. So seeing where we are against the industry and also how much exactly it costs for manual operations really supports the need for continued investment into the electronic space.
No, that makes a lot of sense. And Bob, I want to ask you a follow-up question to what Tom was just talking about. You know, we sometimes have a hard time getting that ROI information from our partners. So then how helpful is it having the CAQH index data for our work, you know, in rule writing and rule maintenance?
Yeah, kind of building off what he said, that the importance of the data is great, you know, for the entire industry. Being that benchmark is really helpful. And so looking at it on the other side, when we write operating rules, we can see where some of the major pain points are, both for providers and health plans, and where the costs are. So if we can look at very broadly, just as an example, prior authorization, it's a very costly transaction to conduct manually for both providers and health plans. So as we tackle those pain points, we can see that we can kind of move the needle from something that's completely manual process, perhaps it's a telephone or a fax PA that you're submitting, to an EDI or partial EDI. You can submit it electronically, and you may have to go through maybe a manual process to upload attachments. But moving that needle forward, you can reduce those pain points and reduce the cost. And we can use the index data to highlight some of those specific pain points that are completely manual parts of the process and what those costs are. So it's a great data source for us on CORE as we look to the industry for how can we look at the EDI standards that are in the marketplace that are part of our industry or other industries, and see how can we implement those to move the needle. So it's very helpful.
That's great. And, you know, we've been spending a lot of time on prior authorization and attachment. So it's good to hear that, you know, you're finding this information source useful and in the work that we do. Thank you, Bob. So my final question is for Reed, kind of a future-looking question here. So how do you see the index evolving in the next 2 or 3 years?
Yeah, so definitely there's two parts to that. One, I'll talk about what we do know will evolve and what we will enhance, and then there's the crystal ball, or what I'd like to see. But you know, recognizing or looking back to where we were 6 years ago when the index started, it was really a limited set of the large national payers, their plans that were contributing the data, and we had a study with Milliman looking at some provider groups there as well. And over the past 5-6 years, that number of contributors has increased. We basically have all of the major nationals that are there, several large regionals, as well as medium-sized statewide plans. But we do continue to recruit and have the need to recruit some of the smaller plans that are out there as well. That's one limitation of the current study that's there that we're wanting to evolve and to grow, just so that we can get a picture, you know, on what adoption looks like. We can maybe assume that those numbers are maybe lower than what we're seeing in the health plan, or I guess on the national plan side of things. So that will, you know, help to further refine some of those savings numbers or potential savings numbers that are there as well. And we'll continue to refine on the cost savings and the different estimates that are going there. Each year we learn more through our work with NORC, as well as with the health plans, and refine those numbers. We've actually seen some of the costs going up, and that's not necessarily an indication of the rising cost of healthcare. It's just been an indication of, like I said earlier, the understanding and evolution of how these different metrics are being defined and calculated. So we'll continue to refine those as well. And then, you know, looking into the future, obviously the data point that we mentioned on claims attachments is a huge opportunity that's there. So we'd like to see, you know, continued research in that area, obviously in understanding around what are those impacts going to be, or what does it mean for alternative payment models, or looking at value-based payment there as well. So that's an area that we'd like to further see growing, evolve, and like I said, we've been measuring and looking at the business or administrative transactions in healthcare here for several years now, but to my knowledge, there hasn't really been any real studies in looking at the clinical side of data there as well. So that's another area where there's the potential to evolve and grow the index over the next 3 to 5 years.
That's great, Reed. And, you know, some of the topics that you just mentioned, like attachments, value-based, those are topics that we're looking at and focusing on, and I think we're going to be planning some webinars in the fall. So I think we're all kind of synced up, and, you know, the things that we're all working on. I would like to thank our panelists and our speakers for joining this part of the webinar, and now we have some time to take another poll. So we've whetted your appetite, we've given you all this information, and you know, my job is to provide information and engage people. So the next polling question is, would you like more information about the CAQH Index? Simple yes or no question. So let's launch the poll. Okay, so let's close out the poll. And so I see that 60% of you want more information. So got it, we got the message. We will share some information and engage with you. This is, you know, really valuable, unique information that's helpful to the industry. So we want to get it out there. And now we have some time for Q&A. I'd like to remind you to please submit your questions by typing them into the questions panel of your dashboard. And so, Reed, we had a couple of questions on, you know, on methodology. I know that's not the topic of this webinar, but can you walk us through a little bit about what that entails?
Yeah. So I know Tom touched a little bit on and I know we had the screenshot of the user's guide and the data collection tool, and the best way to do that would be to do a demonstration of those, but just at a high level from the methodology and how things work. You have CAQH working directly with the health plans through that data collection tool, through that data submission guide, and defining the transactions and what we call fully electronic, what we call partially electronic, and what we call a fully manual transaction. And we sit down and work with them and answer questions on which of those different buckets the numbers would fall into that. And from that data collection tool, the plan then provides their volumes of what they're seeing across the 13 or so transactions that are there, and what's manual, what's electronic, and what's that hybrid in between that's there, as well as there's another section of the data collection tool that allows for them to look at the cost. And basically what they would do, without going into too much detailed information, is look at the staffing at the health plan that is doing those different transactions. Basically, what's their salary, benefits, or the cost of processing each of those transactions for those periods of time, and the volume to do that. We then collect all of those data collection tools. We have individual follow-up reviews with each data contributor to answer any questions that CAQH may have. If any of the numbers look off or not in alignment with what we're seeing, broadly we'll go through and have that and potentially refine the numbers from that, and we'll gather those. We'll do our analysis at CAQH on the health plan side, and then on the NORC side, they'll do a similar but different, obviously a different approach on the provider side, doing the same types of things, but through their instruments or their tools and their interview process as well. They'll come up with their different calculations, and then we'll work together to basically compile or look at the two to see where they line up or where there may be some limitations and what we're seeing behind this. And there is a section in the back of the report that gives some of the details. If you're looking at how are the adoption rates or the cost calculated, that's in there, and probably could be a much deeper conversation to go into that. But like I said earlier, if anybody has questions in more detail, definitely me an email at explorations@caqh.org, and definitely happy to get on the phone and walk through in more detail those specific methodology questions.
And I heard you talk about some of the information that you're collecting, including salary information and things like that. So that information probably shows up in the benchmark reports and gets aggregated, but it's all secure and
exactly.
private.
Yep. So all of that's private. The individual benchmark reports only go back to the individual data contributor. The one other thing too is that if you want to see what that cost information is for a transaction and you don't contribute that data, we don't share that. So you have to play to basically get back. So if you choose only to do adoption rates of some transactions, those are the only numbers that you'll get back. But if you do the full set, including the cost, you'll then get that back. And everything that's reported out externally is completely in aggregate and extrapolated or estimated with it. So it's not tied back to any individual. It's not identifiable back to any individual contributors.
That's great. And Bob, we did get a question about charges for EFTRA transactions that some third parties charge. Can you talk a little bit about that?
No, the operating rules do not address charges that third parties charge related to any of the transactions. So for example, if a provider contracts with a software vendor or with a clearinghouse to submit electronic claims and receive electronic remittance advices, or to receive an EFT transaction from the health plan, again, not directly with the health plan, but through a third party, that's a decision or a contract decision that the provider makes. Again, some health plans also do support third parties or require providers to submit through a third party, and those are all interactions and discussions between trading partners that take place. And the operating rules don't kind of get in the way of that kind of business process or business decisions between trading partners. And that's one of our guiding principles. We don't interact, or we ensure that the operating rules remain neutral so that it doesn't penalize any member within a trading partner relationship.
Thank you, Bob. And so one final question for Reed. You know, we're halfway through the year, so can you talk a little bit about the timeline for contributing this year?
Yes. So as we shift from the results that were reported out for the 2016 index, which was reported out based on the 2015 calendar year, we are currently in the data collection process for 2017 analysis and reporting there. That has begun and basically goes through the summer. So for those that are interested in contributing, there still is time to participate. Granted, we are looking to wrap up the data collection here in August or at the end of the summer with that, and whether that's interest of being from a health plan perspective or the provider perspective, those two are still underway now. So there is time to participate. We'll provide the data submission user's guide and the data collection tool and set up those follow-up calls. And then basically around the end of August, early September, we'll then make a determination on how much data we've received in and basically cut off the data submission period and start doing the analysis with Nork and Milliman and others to start working on the report production so that we can have a report generated by the end of this calendar year for that. So the short answer there is there's still time, but please call as soon as possible so that you can get going, because it may take you about a month to get everything organized and all your different constituents within your organization to collect the data.
Great. That's great. Thank you, Reed. And so we are out of time. I'd like to share the next couple of webinars that we have coming up in the next slide. And as you can, and we're constantly updating and changing and adding webinars. So please go to our website if you'd like the latest information about our programming. One thing to note is that next week's webinar, the first one there on the slide, is for core participating organizations only. So not everybody can register, only core participants. And finally, I just want to thank our panelists, speakers, and our audience for joining us. A recording of the session will be available on our website in the next day or so, and we'll also send you a copy of the slides and the recording so that it's convenient. Thank you very much. Have a good afternoon.